We at Cure attended the 2025 World Conference on Lung Cancer live in person, and we were thrilled to speak with leading investigators, clinicians, and patient advocates. Our goal was to gather the latest insights on lung cancer that matter most for patients. After connecting with experts and hearing their perspectives, we've identified 3 key takeaways that patients should know. Here's what they had to say.
Hi from Barcelona, excited to be here and to really understand the data that we can bring home for our patients that is potentially practice changing. So on Sunday's presidential symposium here at the World Conference on Lung Cancer, we heard about updates for our patients with EGFR-positive disease. One of the studies that we've been waiting for to really understand an update about is from the Flora 2 study. This is a phase 3 study, so it had a lot of patients that were enrolled, and patients were either randomized to the arm that had osimertinib plus chemotherapy or osimertinib alone. And we were waiting to see not only does one regimen help control the disease longer or help shrink the disease better, but truly does the regimen help patients live longer. And what we found out was that yes, if you combine osimertinib plus chemotherapy, it does improve what we call overall survival, so how long patients are living. So on average, we saw about a 10-month improvement in overall survival if patients received chemotherapy with their osimertinib. So that's really important to think about and to have that informed and shared decision-making conversation with your care team if you're newly diagnosed with EGFR-positive lung cancer and you're thinking through your treatment options. Another really good question that they answered was, and probably a very common question that many oncologists get in their clinic, is how long do I have to be on the chemotherapy for? Can I just be on the osimertinib pill at some point? And on average in the study, we saw that patients were on the chemotherapy portion for about 8.3 months. And so that gives you a little bit of perspective about how long patients are able to tolerate chemotherapy, and most of them unfortunately have to discontinue the chemotherapy because of things like side effects. So that was just a recap of the Flora 2 study. Again, there were a lot of really exciting studies here. Continue to follow along and take care.
So there is a lot going on from a research side in the treatment of small cell lung cancer. And it's horrifying that anyone has to be in a situation where they need these treatments. But academically, it's exciting to see such advances in these treatments. In the limited stage space, we now have the incorporation of immunotherapy after chemo and radiation. So this is limited stage where we're treating with a goal of cure. The standard of care up to this point had been chemotherapy and radiation and then monitoring. And what we've found is that by adding 2 years of immunotherapy, that's a 30-minute infusion once every 4 weeks for 2 years, most patients don't really end up with a lot of side effects. This is something that's pretty well tolerated. That with that, we see improvement in the time to recurrence. I would speculate in saying actually the number of patients cured, and we need longer term before we start using these words in a scientific way, but what it looks like is that we may actually see an increasing number of patients cured, which is of course the real goal in this, and that overall people live substantially longer. And so overall, this has been a very good signal for how effective the drug is, while also does not have the same kind of side effects that we see from chemotherapy. This has been a huge advance in metastatic stage 4 and now also in the earlier stage curative setting. In the metastatic setting, or stage 4, incorporation of immunotherapy has been an important part of the standard of care at this point for 7 or 8 years. But we have so much more going on now also. We have a targeted chemotherapy we call antibody-drug conjugates. This is essentially an antibody is something that kind of finds, we think of it like, maybe like a key that finds the lock somewhere, and that's how it opens a door to deliver the chemotherapy. And there are multiple drugs in development that are showing some very promising results, really working for a substantial number of patients in the later lines of therapy when first-line treatment reliably works. It works great for the majority of people. But as people get further along, some of the classic chemotherapy drugs, they can work, but these work better. And so it's exciting to see those advances happen. Of course, we also have immunotherapy in tarlatamab. This is a drug that grabs the tumor cells by a receptor called DLL3, grabs the immune cells by a receptor called CD3, essentially bringing the immune cells and tumor cells together to create more of an immune response. And this has worked remarkably well, and this is now the established second-line treatment for patients, and something that has shown some very promising results, particularly in that we're seeing some patients years on where they're having ongoing disease control in that second-line setting. So these are a handful of what's going on. There is much more. I could go on for quite a while, which is a new thing in small cell lung cancer to have that. And maybe just to highlight that anyone diagnosed with small cell lung cancer is essentially getting a drug that is new within the last 10 years. And there is more going on right now in the development of new promising therapies in trials. There's more going on now than the culmination of everything up to this point, which is just to say that when someone's diagnosed today and the common question I get is, okay, how long is my treatment going to work? How long am I going to live? Which are impossible questions to answer. But looking forward, I'm very optimistic that that's going to be a very different number than what it is looking back. And so there's a lot happening.
Well, in EGFR mutant lung cancer, we have several options. We have TKIs, so oral pills, osimertinib. We have TKIs plus chemotherapy, more intensive. And we also have the combination of amivantamab-lazertinib, which is oral pill plus injection, but it's not chemotherapy. It's actually a targeted agent that is administered through infusion. So what we call the Mariposa regimen with amivantamab-lazertinib, it's chemo-free. And the efficacy of this regimen is actually quite similar to that of chemotherapy plus the TKI. So it means that we can do better than only a pill in this situation with some combination. So either with chemotherapy, probably more aggressive with chemotherapy-related toxicities, or chemo-free, and this is the Mariposa regimen. In the Paloma 2, we adapted the Mariposa regimen to deliver a pill plus subcutaneous injection of amivantamab. So subcutaneous is actually easier than intravenous because it allows to deliver the drug only every 4 weeks, as we showed during the meeting. We show the efficacy of subcutaneous every 4 weeks plus the daily oral pill. And the efficacy is actually similar to the intravenous every 2 weeks plus the oral pill. So it means that we can really adapt the delivery of this combination with similar efficacy, high response rate. It works in more than 80% of the patients. We do not have yet duration of response, this kind of thing, because this is really early data, but it's important data because we can implement that in the clinic. When amivantamab subcutaneous is available, we can implement the dosing every 4 weeks, which facilitates, obviously, the life of everyone, because it's coming at the hospital only every 4 weeks, and it can also be administered at home. So it really facilitates the delivery of the treatment with a similar efficacy.